Hello, I'm Bethany Samuelson Bannow. I am the Deputy Editor of ASH Clinical News, and we are here with our on-site coverage, talking with folks who have some really fascinating abstracts. And it's my pleasure to introduce Dr. Rachael Grace and Dr. Michele Lambert, and they're going to talk about their very impressive abstract on autoimmune hemolytic anemia in pediatrics. Doctors Grace and Lambert, I'd just like to start by asking, what was the inspiration behind doing this study? What led you to try to answer this really interesting question?
In our clinical practice, we see a lot of kids who have autoimmune hemolytic anemia, even though it's quite rare. It only affects something on the order of 0.2 to 2 per million children in our centers, which are referral centers. We see quite a few children with autoimmune hemolytic anemia, and we don't have guidelines to really point us to how these children should be, what kind of diagnostic evaluation they should have, what kind of treatments lead to the best outcomes, what are the long-term issues that patients have. And so we discussed in our consortium, a group of pediatric investigators that work together to do better, to understand immune cytopenias in children, improve outcomes. So we talked about a project in autoimmune hemolytic anemia so that we could try to understand the evaluation that we should be doing, and if we could maybe move the dial in terms of treatment for these children.
Yeah. Do you have anything to add?
I don't have anything really to add. I think the hardest part about taking care of these children is that we're really using adult-derived guidelines and recommendations for how to manage these patients, and we don't really have anything that's specifically pediatric dedicated. So that was part of the goal, was to try to figure out, should we be doing something different, because children are not just small adults. So
very true. My children would agree with that. So you guys had a really creative approach to trying to get a large enough sample size, which, as you just discussed, is very hard. So maybe can you give us kind of the 30,000-foot overview of your study design, and then we'll kind of talk about the key findings?
Sure. So the study was offered at all of our, we have an ITP consortium that's really focused on immune cytopenias. It was offered to all of the members of that consortium. We had 15 centers that participated in this study, and we had over 400 children who were reported, which is quite significant in this very rare disorder. And it was going through the records of all these children in terms of the types of evaluation that they had, the treatments they had, and then their outcomes and other diagnoses. And what we had a number of different important findings as part of the study. One is that these children have a very high rate of underlying immune disorders, other autoimmunity, and that many children, almost half of them, had a chronic or relapsing remitting course, so really had a very long period of time dealing with autoimmune hemolytic anemia. And when we look at the treatments, it's really with kind of old treatments that we're still using in these children. So the most common treatment, both at the time that children were first diagnosed, were corticosteroids, and then with relapses, and the children who had relapses, it was anywhere from having 2 episodes of this to 9 episodes, and repeated courses of corticosteroids, and then using oral immunosuppressant agents or rituximab really as the other therapies. What we saw in these children is that the outcomes aren't what we would want for them, and we were very surprised and alarmed to see that there was over a 9% rate of mortality in this pediatric cohort.
Yeah, that's really sobering statistic. And I'm curious if you had any opportunity to delve into the causes of that mortality. Was it from anemia, you just couldn't keep up, or was it from infection? Was it from maybe malignancy or other autoimmune disorder? Any ideas about that?
Well, one hypothesis we had, when we looked at the data, were maybe the children who had more underlying issues would have poorer outcomes. And so we were interested to see if children who had Evans syndrome, so more than one immune cytopenia, or who had an underlying immunodeficiency, or maybe who had other autoimmunity like lupus or an immune neurologic disease or inflammatory bowel disease. Maybe those were the children who had more poor outcomes. But actually, when we looked at the association with mortality, it wasn't associated with those factors, and it wasn't associated with really any of these characteristics that we could identify, including even, surprisingly also, the type of autoimmune hemolytic anemia. So we see that the warm autoimmune hemolytic anemia subtype is more likely to have a chronic course, relapsing course associated with Evans syndrome, but that also wasn't associated with the mortality. And so I think now that we've recognized how high this is, we really need to explore those patients in more detail. I think it's an unexpected finding in the cohort, and so we really, as part of our data collection, didn't ask a lot of questions about, what a patient's mortality was related to, because we were expecting, we asked about it, but not in detail. We weren't expecting to have numbers where we could actually look in more detail, or that we would be able to do that. So I think we may need to go back to those centers who had patients who had died and find out more details around that.
Yeah. There's never a study you get to the end and you feel like you've answered all your questions, is there? Is there anything you two are going to do differently in your practice now as a result of these data? Changes in counseling of families, different degrees of aggressiveness in your treatment?
I think there are a number of important findings that really do lead to practice changes. One is we could see that there was variability in how in the diagnostic evaluation for the patients, what type of immune testing was done. About a third of patients had genetic testing, and a third of those had genetic findings for an underlying immunodeficiency. And so we can see from that data that patients, particularly with warm autoimmune hemolytic anemia, need an expanded diagnostic evaluation, particularly looking at autoimmunity and immunodeficiency, and have genetic testing to try to get to an answer about the underlying etiology for the autoimmune hemolytic anemia. I think, too, because patients with warm autoimmune hemolytic anemia have a much higher rate of a chronic course or relapsing remitting course, that really speaks to the need potentially for considering non-steroid or steroid-sparing agents early in the course to try to get off steroids more quickly, to decrease potentially the risk of infection, and just all of the complications of long and repeated courses of steroids. And I think this really, I hope, really identifies this unmet need in this pediatric population. And so I think, just as researchers in this area, I'm hoping it will support an interest in industry and other investigators in developing treatments, and in treatments that are in development, bringing them to pediatric trials. That they're at this meeting, a lot of abstracts for new immune modulating medications for ITP and autoimmune hemolytic anemia, warm autoimmune hemolytic anemia in particular, and the studies that are being presented, or the trial designs that have been presented, are for adults. And so we're hoping this helps to bring more trials to children.
Okay, industry partners, you heard the call to action. We expect some phone calls. You already mentioned that maybe one of the next steps would be to get a little bit more detail on mortality, cause of death, things like that. What do you see kind of the next couple of steps being in terms of how are you going to move your research forward now that you've had this really impressive and alarming finding?
Well, I think one of the things that we want to do is to try to come up with a way to standardize the evaluation of patients. There's still a third of the patients had genetic testing, but that means 2/3 did not. And since a third of those who had testing done had a genetic finding that was diagnostic for an inherited disorder of immunity, I think it's really important that we think about systematically evaluating all of these patients in the same way, and doing genetic evaluation of full immunologic workup, particularly in those children who present with warm autoimmune hemolytic anemia. I think that disease is not so benign, even though the general impression and many people think it's a benign disease and they'll get better, and it turns out they really don't.
Yeah. Forgive my ignorance as an adult hematologist, but you have both now mentioned underlying genetic causes. And are there specific therapies for that right now, or is this really we need to find the causes in the hopes of developing therapies?
It's a little bit of both, actually. For some of the inborn errors of immunity, we do have targeted therapies, like ruxolitinib for JAK-STAT pathway targeting, and other JAKI, abatacept for CTLA-4 deficiency, and other drugs that target specific immune pathways. So what we're hopeful is that we can continue to identify these different pathways that are involved, and then more targeted therapies hopefully have less morbidity and less mortality overall in the end by not being as immunosuppressive and being more directly targeted towards the defect that's present.
I think too that identifying an underlying immune disorder identifies a bigger problem than just a hematologic issue. So I think because the blood counts are easy to see and monitor, we get very focused on the Evans syndrome or autoimmune hemolytic anemia. But if a patient has an underlying immunodeficiency, they're at risk for immune pulmonary disease, immune GI disease, or neurologic issues, and those need monitoring, and we need to see if our treatments are effective for any of those issues that are ongoing. And I think too, the consideration also for stem cell transplant in that population too. So it really expands the way that we think about the patients, and I think probably knowing what the underlying issue is helps to improve their overall outcomes.
Well, thank you for this really important, somewhat saddening research. Any final words that you want to share? Anything that you want to make sure that our viewers hear and understand that we haven't gotten to?
I think one thing that was very striking to me yesterday when I was at the plenary session is looking at how amazing the outcomes have become for B-cell ALL, which has the same incidence in childhood as immune thrombocytopenia, for example. And when we look at those outcomes and then compare that to what we see now in this pediatric patient population with autoimmune hemolytic anemia, I think we just need to make a point of recognizing these conditions that fall into classical hematology are not benign, as Dr. Lambert said, and that we need better outcomes for these children now that we've made so much progress in children who have cancer.
Well said. Well said. Well, thank you both for joining us, and thank you to our viewers for joining in and listening to our on-site coverage again here at ASH 2024. More content will be available in the pages of ACN as well as on our website. Thank you.